Hello again, everyone. This is Henny. I passed my AMC Clinical Exam a while ago, and I'm making some videos to help my peers pass this exam. So today we're going to talk about the anxiety cluster. It's another psychiatry tutorial, and by the end of the session, hopefully you'll get an idea about how to approach patients who present with nervousness or anxiety. Okay, so let us move to the next slide. Okay, so what are the cases of anxiety or nervousness that might present in the exam? Of course, any case might come in the exam, but these are the more important ones. You have to put your focus on these cases. Of course, there's panic attack. There could be panic disorder, sometimes with another problem like claustrophobia or agoraphobia. It could be post-traumatic stress disorder. Please read Handbook Case Condition 85. It's a very good case on post-traumatic stress disorder. We also have generalized anxiety disorder or GAD. We have obsessive compulsive disorder or OCD. Adjustment disorder could present with depression or with nervousness or stress. So be aware that it might adjustment disorder might present with nervousness. So we have to rule out both depression and other stress conditions. And then, of course, there's lifestyle stress. There's another handbook condition on this. I do not recall the number. I will leave it in the comments which handbook case it is. And then there's hyperthyroidism, which is an organic cause, but the AMC loves organic. So when a patient presents with nervousness, ask about thyroid. So we will discuss this further. All right. So how do we approach? If you have watched my previous video on how to take psychosocial history for mood disorders, you will understand that this approach is very similar to the approach we had to mood disorders. So the format is pretty much the same. The order could change depending on the case scenario, but we have to cross-check all these items in this slide. So we have to mention confidentiality, preferably at the start. History of presenting illness, I will discuss further what we should ask. And then there's the mnemonic heads, which is for home situation, education, alcohol, drugs. The S could stand for a lot of things. It could be about friends and whether they socialize. It could be about smoking. It could be about their sex life. So we need to decide which one of these S's we're going to choose depending on the case scenario. Then definitely the mood. And here it's in every case, as I mentioned in my previous video, we have to cross-check anxiety. But for this one is a major item for the anxiety cluster. I will discuss further what we need to ask. Then we have evidence of psychosis. Always ask in any psychiatry case, look for evidence of psychosis. It could be the main ones within the limits of our exam is hallucination, delusion, insight, cognition, and judgment. If it's relevant, I will tell you when we should ask and when we can skip the insight, cognition, and judgment. And then, of course, it's the organic screen, which I will tell you what they are, and past medical and family history, just like any other case in medicine. Okay, so history of presenting illness. This is not limited to psychiatry. So in every case, whether it's pediatrics, obstetric gynecology, any case in general in medicine, we have to cross-check these items. We have to ask history of presenting illness. When did your problem start? What do you think might have led to this? or what happened before? Anything making it better or worse? How has this affected your day-to-day life? Plus, in psychiatry cases, we can also add, have you tried anything to cope with it? So depending on the case scenario, it might be different. Don't just stick to some pre-prepared questions and go on like a robot. This is definitely not what they want to hear from us. Okay, so I've already explained this slide in my previous video, but just to give a quick rundown on it, definitely we need to ask about mood. So the way we ask it is like, how's your mood been? Have you been sad? Have you been happy? In simple layman language. So if the patient gives you low mood, tells you he or she is sad, you definitely have to proceed with the mnemonic AMC CAPS, which stands for mood. Again, here we ask mood because we want to rule out bipolar. We have to ask, have you ever felt the other way around? S is for sleep, I is for interest, G is for guilt. Do you blame yourself for anything? Of course, we have to ask about their energy, their level of concentration, appetite, psychomotor status, and suicidal ideation. To quickly tell you what questions are preferred to ask, of course, for sleep, we have to ask, do you have any difficulty falling asleep, or do you wake up early in the mornings? And immediately ask any nightmares, flashbacks, or vivid dreams. Nightmares and flashbacks are for post-traumatic stress disorder, and vivid dreams is usually associated with grief. Then we ask about interest. Are you still interested in the things you used to enjoy? Guilt. Do you blame yourself for anything? Energy. Do you have enough energy to proceed with your daily activities? Concentration. Are you able to concentrate on your daily activities? Any changes in your appetite? Don't just directly ask loss of appetite, because overeating could happen in psychiatry issues as well. Psychomotor status. We ask, have you noticed that you're doing your daily tasks a lot slower or a lot faster than your usual? And of course, suicidal ideation, depending on the context, we have to ask, have you ever felt like harming yourself or others? Or do you tend to think a lot about dying? Then we have normal mood. Still, we need to ask some screening questions. So we usually need to ask guilt, suicide, and sleep. And if there's elevated mood, immediately think about the mnemonic DICFAST, which stands for distractibility, indiscretion, grandiosity. It could be grandiosity, flight of ideas, and less asleep, and being talkative. So that's a mnemonic. And so the items that are underlined here are the ones that we have to ask, but the rest we need to observe. So for indiscretion, for instance, in the scenario, a patient might tell you that he is extremely energetic and happy. Then we need to ask, what have you been doing lately? I can see that you just told me that you've been a lot more happier. So how have you been managing this? Have you been engaging yourself in party, in sex, in drugs? Have you been doing any investments? And then grandiosity. The patient with elevated mood might tell you, this might happen a lot, might tell you that everyone's jealous. Then we can link it to our question like this. Why do you think they're jealous? Do you think they're better than them? Do you think you have any special powers? And of course, again, we need to ask about their sleep as well. Next is the main area, our main focus, which is anxiety. So the main question here is, are you an anxious person? So in the anxiety cluster, they're going to say yes. They usually will say yes. So next thing that we have to do is that we need to think about the anxiety cluster. There is this mnemonic, it's made by me, and it could be 3POG, it could be 3P-GO, whatever works for you, as long as you remember these items. So the 3Ps are panic attack, panic disorder, post-traumatic stress disorder. The G stands for GAD, and the O stands for OCD. So if you ask a patient, are you an anxious person, and they say yes, you immediately need to think about the 3P-GO. So whenever we approach a case or we approach a patient, we usually have a main diagnosis, which our findings are more in favor of that. And we obviously will have a few differentials as well. So whatever our main diagnosis is, we have to ask all the items of the criteria related to that diagnosis. We will discuss the criteria for each of these further, but remember that you have to cross-check the criteria for it to confirm, for instance, that this case is a case of post-traumatic stress disorder. And then for your differentials, 2 screening questions for each of them is enough. So I will explain what these screening questions and what these criteria are. Okay, so for panic attack. For panic attack, there's a mnemonic called panics. So the criteria is the panics, 4 out of 6 of the panics should be present in a patient. And that's only when we can label the patient's condition as a panic attack. 4 out of 6. So these the mnemonic, the panics stand for P is for palpitation, A for abdominal pain, N for nausea, I for intense fear of dying or going crazy, C chest pain, and S is sweating. And the symptoms should usually peak within 10 minutes of their onset and do not last more than 30 minutes. That's the criteria for a panic attack. So the underlying items here again are the ones that I personally prefer to ask as screening questions. For instance, if my main diagnosis is not panic attack, I'm not going to go through and all this mnemonic. I'm not going to ask every question. I'm just going to ask, have you been experiencing any racing of your heart for palpitation? And I'm going to ask, have you ever felt any intense fear of death? Or when you had that episode, did you feel like you're about to die? Were you scared that you're going to die? So these are my favorite screening questions for a panic attack. This way, the examiner will know that you're definitely trying to rule out panic attack. And if the answer to these 2 questions is yes, okay, then my main diagnosis is most likely a panic attack. I'm going to ask the rest of the panics. All right. Then we have panic disorder, which could be plus minus agoraphobia, plus minus claustrophobia, and many other issues. So say we have the patient said yes and filled the panic attack criteria. Of course, in the history of presenting illness, we have to ask the onset and how many times it has happened. If the patient says more than once, then we need to rule out panic disorder. So panic disorder, again, have 4 out of 6 of the panics, and it obviously happens more than once. It happens more than once per month, every month. It happens quite frequently. Patient usually worries about having them again and worries about consequences of the attack. So if the panic attack has happened more than once, then we should ask these two questions. Do you feel ashamed of the attack happening in front of others? Do you avoid going back to the place where you had this attack or this episode? This is how we differentiate a panic attack and a panic disorder. Then we have post-traumatic stress disorder. Of course, when we ask history of presenting illness, the patient's going to tell us. I already mentioned that we have to ask about triggers. So usually in PTSD, a traumatic stressor has to be present. And if you remember, when I explained how to ask mood, I mentioned the way to ask, we have to ask sleep there as well. If the mood is low, sleep is part of the MCG caps. If the mood is normal, sleep is part of the screening questions. If the mood is elevated, lack of sleep is part of the dig fast. So we have to ask it anyways. And I've told you, the way we ask sleep, we don't just generally ask, how's your sleep? We have to specifically ask, do you have any difficulty falling asleep or do you wake up early in the morning? That's for depression. Then we ask any nightmares, flashbacks, that's for post-traumatic stress disorder, and any vivid dreams for grief. So PTSD is covered and we do not have to worry about it, but in case the patient gives a yes to both the trigger and the sleep question, then we have to fill the criteria. So then PTSD is the most likely diagnosis and our main diagnosis, and we have to ask, and we shouldn't limit ourselves to the screening questions. We have to ask the whole criteria. So the last two is avoidance of reminders and hypervigilance, exaggerated startle, or irritability. So whatever way we're more confident, we can ask these. Then we have GAD, or generalized anxiety disorder. Again, there's a mnemonic for this called Watchers. So in the Watchers, W and A should always be there. If not, it's not GAD. Then we have the chairs or teachers. So at least 3 of them have to be there for at least 3 months. So what are these Watchers? Worrying, anxiety, tension, headache, or tense muscles, whichever you like. You can ask. Concentration problems, H for hyperirritability, E for energy is low, and R is for restlessness, S is for sleep problems. So again, the underlined items here are the ones I prefer to ask for a screening question. So do you tend to get a lot of headaches? Do you feel tense or do you feel on the edge? And have you been feeling more irritable lately? We can obviously ask other questions at screening, but I think these are more to the point. This is just my personal opinion. You can pick whatever item you like to ask here. And of course, remember that worrying and anxiety should be there. And if the answer to our screening questions is yes, then we need to ask the rest of the criteria to confirm that this is GAD. Then we have the OCD criteria. We have obsession and compulsion should be there. So of course, the way to ask this from the patient is any recurrent or persistent thoughts that you find difficult to resist. That's the way to ask about obsession. If the answer is yes, it's better to ask, do you tend to repeat things over and over, and are you a perfectionist? If again it's yes, then we have to ask about, we need to ask the further questions, like how much time do you spend? That's for the compulsion. For instance, the person might say that when I come across the word pillow, I have to stand up and sit down or do 50 squats, for instance. That's a compulsion. Then we need to ask, okay, how much time have you been spending doing this? And has this interfered with your normal routine? And of course, in order for us to label a condition as OCD, we have other causes such as substance abuse, other medical disorders or mental disorders have to be ruled out. We all know this. Then we have adjustment disorder. So for adjustment disorder, it's usually there is an identifiable stressor within the last 3 months, and symptoms do not persist more than 6 months after the stressor or after the consequences of the stressor have been removed. And of course, like OCD, other mental and medical disorders have been ruled out. There are many different types of adjustment disorder, but within the limits of our exam, the main types are anxiety or anxiety plus depression, like a mixed form. And last but not least, we have to ask organic screen. It's really important. This is just my mnemonic again here. As long as you remember the main items for organic causes, you'll be safe. So P time, P for pain, T for trauma, I for infections, M for malignancy, and E for endocrine. So for endocrine, thyroid is really, really important in the anxiety or nervousness cluster. So do not just rely on one question for the thyroid here. Do not ask any weather preferences. You can ask it, but complete it with further questions, asking about the bowel movements, asking about sweating, asking about dry skin, coarse hair, whichever, just at least 3 to 4 questions try to ask. And then, of course, it's a female in perimenopausal age. Try to rule out perimenopausal symptoms as well. And of course, as I mentioned earlier, past medical history and family history should be there as well. This is an outline of how we have to approach anxiety. This is very similar to the one we had for mood disorders. So for psychosocial history, of course, confidentiality should be there. History of presenting illness, HEADS, which is the home situation, education, alcohol, drugs, and social life. And then we have mood, low, normal, elevated. The mnemonics are there. And anxiety, 3P go. Psychotic features, organic, past medical history, and family history. And for psychotic features, please refer to my video on mood disorders, and you'll get a brief on how to ask questions related to hallucination, delusion, insight, cognition, and judgment. And I promised earlier that I'm going to tell you when we're allowed to skip insight, cognition, judgment. Of course, if it's time, it's best to ask. But those times where the task is going to ask us to assess the risk, then we definitely need to assess insight, cognition, and judgment. The times when the task includes management, definitely we need to ask insight, cognition, judgments, and it's better not to skip. But when our task is take a history and mention the diagnosis differentials, then if we're really running out of time and we really want to focus on our differential questions, we can skip insight, cognition, judgment, and it's not like we're going to be considerably down marked. Okay, so this is a sample case. We're in a GP practice, and a 47-year-old male presents and complains of feeling overwhelmed. This is very generic. And he is a father of 2 and works full-time as a banker. He has never felt this way before and is quite concerned that he is not able to manage his stress. So feeling overwhelmed and stress are hints this is probably anxiety cluster, but still we shouldn't be misled by the STEM. We should still try to cover mood issues. So in our 2-minute thinking time, we have to think about anxiety cluster. And we have to think about this. We have to visualize this and come up with our own mind map and approach the case. So the tasks here are: take a psychosocial history for 6 minutes, discuss the possible diagnosis and management. All right. So what could be the positive findings for this case? So this person is going to tell us his son has been diagnosed with cancer 2 weeks ago and is currently staying at the hospital. He's worried and doesn't know how to manage his stress. Okay, so there's this trigger we're having here. Then the findings we're going to have in the heads is that both him and his partner are very busy. They also have a younger daughter who's fine, which is doing fine at the moment. So always in your heads, when confronted with a main trigger such as son being diagnosed with cancer, don't forget about other family members. Don't forget to ask about support. So how's your wife doing? How's your other child doing? Are they supportive of you? How are they coping? How's your son doing at the hospital? Things that we ask in real life. Do not become preoccupied with the structure. Try to, at the same time, try to act like a real doctor as well in real life. Of course, all of you are real doctors, but try to act like a little bit like how you approach patients in real life. So this is in the previous slide, we can see that there's a trigger and the father is obviously unable to cope. Whenever there's coping difficulties, immediately think about adjustment, unless there are other findings, there are other positive findings. When there are no other positive findings, if the timing is okay, just label it as adjustment disorder and you'll be safe. So again, we have the 6 C's, which is condition, clinical features, causes or risk factors, complications, commonality, and care. So care itself involves investigations, treatment, and management. So how do we explain adjustment disorder? It's an emotional and behavioral reaction. It happens when people experience significant coping difficulties, stress, or low mood. And the reason is usually facing considerable life changes like losing a job, moving to a new place, and in your case. So always specify what might be the main trigger in that case specifically. So in your case, is your son being diagnosed with a serious condition? Complication. If left untreated, it might lead to severe depression or even self-harm or lifestyle disturbances. It's not an uncommon condition, and good thing it's manageable. Then we move on to care. So that's when our task has management. Remember, I mentioned this earlier, when the task only mentions management, it involves investigation and treatment. Okay, so investigation. Always do these blood tests as a screen for organic. Because in our history, we asked P time. We asked our organic. We did our organic screen. So in the care part, we have to show that we weren't asking those just for nothing. We were really thinking about it, so we're going to investigate. Full blood exam, inflammatory markers, kidney function, liver function, and thyroid function tests. Of course, always go with non-medical and then go with medical. So adjustment disorder does not need medical therapy. Again, there's this mnemonic SNAP. which is smoking, nutrition, alcohol, and physical activity. We can talk about those. There's also talk therapy, cognitive behavioral therapy, and then we have management. So for management, we have the mnemonic 5R. Refer. We always refer to support groups. We always arrange family meetings. We always arrange social workers, especially if there has been disturbances in daily life or work. The second R is review, reading material, red flags, and reassure. So with the red flags, it could be suicidal ideation, severely low mood, and then reassure. You can tell them again that don't worry, I'll do my best to help you, I'm here for you, and this is manageable. So differentials for adjustment, if our task mentions differentials, we can mention major depressive disorder, lifestyle stress, post-traumatic stress disorder, hyperthyroidism. It could, these are the main ones. These are the main ones for this case specifically. And yeah, so I think we're almost done with the outline. If you want me to explain or go through any specific case, just leave me a comment in the comment section, so I'll make sure I'll make a video for that. And to support this activity and sharing free videos on this channel, please make sure to subscribe my channel and turn the notifications on, and I'll make more videos. So good luck and hope you all pass your exam soon.